All right, good afternoon, everyone. It's 4:05, and it's time for another session of NASCI's Curious Cases webinar. Um, Thank you all for joining. Hope everybody had a fantastic 4th of July weekend and everybody's refreshed and ready to show cases, ask questions, participate in the discussion of all the cases. So I do have a couple cases prepared, but I would like to see if any of you guys have cases that want to share with the team. So if you do, just let me know.
Hey, I could show something. It's Ian Drexler.
Dr. Drexler, all right, then. I'm gonna make you presenter. You should get a window asking you to present, and if you want to present, then you just accept it. All right, let's see. There you go. We can see your screen. Take it away. I think you're still muted, but we can see your screen.
Sorry. All right. Can you hear me?
Yeah.
Great. So this is a quick case. It's a 55-year-old marathon runner, coach, healthy. For some reason, at an outside institution, ended up getting exercise stress exam that showed an equivocal EKG. That led to a nuclear stress test that showed an apical defect, and that led to a coronary angiogram that showed no obstructive disease, but some interesting findings. And I'll start with that. So here we have our LAD, and then we see that there's this branch coming off that is very serpentine, and on some of the images, I guess we'll have to take their word. They felt they saw a connection from this tortuous branch coming from the LAD to the pulmonary artery, and that's what led to a coronary CTA that I'll be showing. What wasn't described, this is the RCAs, or nice C view, and we see that there's a conus branch that comes off, and towards the distal aspect, it becomes a little maybe ectatic and tortuous as well. So, is there a way that we're going to be putting this all together? So they ordered the CTA, again, with the history of LAD to PA fistula. I'm going to try first showing as a movie. I'll try to slow it down. Sorry, let's see if I can slow it down quickly. Yeah. Well, let me just replay this. And then I have some of the images on PowerPoint. You just look in this area here. Speed settings. Okay, I think I slowed it down a little. And you get the sense that you see what we were seeing on the coronary angiography, where we have this tortuous and ectatic vessel coming off the LAD, and not only does it look like it's kind of diving to the pulmonary artery, but it then continues and connects with this conus branch. So here we see the dilated branch coming from the RCA. And then I'll just show a couple key images. So here we have where this vessels somewhat, aneurysmally dilated. The vessel coming off the LAD is about 1 to 2 millimeters. Here it goes up to 5 to 6 millimeters. And you kind of see this blush of contrast, that kind of comes from the vessel and goes into the pulmonary artery. And if you kind of squint a little, you even see that in the pulmonary artery, there seem to be 2 different densities from the contrast that's getting into the pulmonary artery. So then, how do we put this all together? And this is something that I've probably seen a couple times before. I'm not even sure if I'm going to be pronouncing this correctly, but Vieussens arterial ring, named after a French anatomist, and it's essentially a connection or a collateral pathway between the conus branch of the RCA and the proximal LAD, and then rarely it may be associated with aneurysm and/or fistula, which is what we have in this case. We have aneurysmal dilatation with visualization to the pulmonary artery. This patient went for a cabbage, and this was all sorted out in the OR, and the patient recovered well.
So can I ask a quick question?
Yeah, go ahead.
So the Vieussens ring, that's a connection between the conus and the LAD, but that does not normally have that fistula, is that correct?
Correct. Yeah. So it's a known collateral pathway between the two systems, but it typically does not have the fistula to the pulmonary artery. Correct.
Thank you.
I have a question. This is Diana Litmanovich. Why was this patient taken to the OR? Was really the assumption that this fistula and Vieussens pass have implications in terms of patient symptoms and nuclear medicine findings?
I wasn't 100% sure about the reasoning, but I presume that that was their thought process. Obviously, I mean, given the location, I'm not sure we know for sure that it's going to cause some sort of apical defect unless it's shunting blood away from the distal LAD. I really don't have an answer for that.
There was a still phenomenon, right? It was on the program, you could see it going to the pulmonary artery, so there definitely was some stealing going on.
Right. I mean, which again, would make sense. But yeah, I didn't get the clear picture from the notes that this is precisely the reason.
Ian, can you show the first angiogram, the LAD angiogram you showed?
Sure.
That one. So just a quick tip for the trainees, and you can stop it there. So there's a couple things that are interesting here. As radiologists, we're not always used to seeing these images. When you're looking at these, angiographic images, the best way to differentiate and know which is the LAD versus a diagonal, a ramus intermedius, or sometimes a circ, depending on the angle they're doing. You see the branches coming out of the vessel pointing towards the patient's feet. That's the best way to know that you're dealing with the LAD. That means that those are the septal perforators. They always is a horrible word in medicine, I guess, but almost always point towards the patient's feet. So that's how you can distinguish which corner you're looking at. And the other thing here, you see there's very early opacification here. I'm pointing with my cursor, you cannot see it, but Ian, you can point at the pulmonary artery, the MPA, and you can see if you're getting confused if that's the MPA or the aorta. Your pulmonary artery is always going to be the most anterior structure on the heart. Just think on cross-sectional. It's always the most anterior structure, other than in TGA cases and funny congenital cases. Your pulmonary artery should be the most anterior structure in the heart. So you can see there is the most anterior when you follow the cardiac contour. So that's going to be your pulmonary artery opacifying with contrast. All right. Just wanted to add those two comments for those trainees on the call. Awesome. Thank you, Ian. Good case.
Thank you.
All right. Anybody else has cases they want to share?
Since I cannot share my case, I can actually describe it, and I would like the input of the group, if I may.
Please go for it.
So the clinical presentation is a 71-year-old gentleman with a 3 years ago history of 50% narrowing of right coronary artery, a calcium score that puts him at the 40th percentile, and no actual history of myocardial infarction in the past, and no actually history of angina. Now, the gentleman presents with ventricular tachycardia and tachyarrhythmia. And the reason we see him is because he is enrolled into the ventricular ablation protocol study in order to obtain the ventricular ablation to control his ventricular arrhythmia. So we do the cardiac CT. We do see dilated left ventricle. We don't see, at least on the first and the second glance, and not on the delayed imaging, on the CT areas of definitive scar, okay? We also see that there is extensive coronary artery disease, but no severe stenosis or obstruction. Now, what we do see is the anatomy of the left ventricle that would be very much inclining us to say that this is a non-compaction myocardium. Now, we do the measurements, and we are close, but we are not really at the cutoff, okay? We are missing a few millimeters to really reach the cutoff. And this is not the first case I see where the anatomy is very much suggesting on CT non-compaction syndrome, but we don't make the cut. So my question to the group is, do you guys see it often on CT? And what do you do with those cases where the clinical presentation and the appearance are very much in favor of that syndrome, but we don't really make it based on our millimetric measurements? So that's my case, virtually presented, and my question.
Okay, I can try to start. Just I wanna get just a couple things clarified. Number one is this was a finding on CT, not on MRI, correct?
Correct.
And this is a patient where you found also that there was a dilated left ventricle. So there is a non-ischemic cardiomyopathy going on.
So the assumption was when the patient was referred that this is ischemic. It's just that we get something to suggest that this is ischemic.
Okay. All right. What I've noticed, and I have had these conversations with other people, is that anytime we have a dilated cardiomyopathy, we tend to visually see non-compaction morphology as part of the manifestation, the imaging manifestation of it. The thinning of that myocardium, or it's not really thinning, but that stretching of the myocardium just makes that much more apparent. So the people that I've talked with, we kind of believe that it's very hard to say that a patient has a non-compacted cardiomyopathy when you have a dilatation of the left ventricle, just because of that. So if your measurements are borderline at best, I probably would just call it dilated cardiomyopathy, either ischemic or non-ischemic, but I would just call it that, and I would not necessarily discuss the non-compaction part of it.
Okay, that's very interesting. Thank you.
And I'll tell you, I had this conversation with, Scott Flam. I had it with Scott a while ago.
Okay. And you see that the higher percentage of patients with dilated left ventricle presenting with, let's call it a pseudo non-compaction, just because of the stretching?
I don't know if I don't know if I would say that. I've never kept track of it. I just know that when we've seen it and we kind of question it, and then it's like, you know what? No, it's very close to call, and the patient has a dilated ventricle anyway. It's probably just part of that. But I couldn't say that it's okay. That I see it all the time or half the time. I really don't know. And
okay.
And I think we've discussed a case or two like that, haven't we?
Yeah, no, yeah, it comes up.
Some authors says that hypertrophic lesions in dilated cardiomyopathy could be an epigenetic phenomena for cardiac remodeling. And I think there's a report, an article in the literature that comparing patients with dilated cardiomyopathy with and without hypertrabeculation, there is no difference in the follow-up regarding some adverse events.
All right, there you go. Some good clinical background too. Thank you, Jordi.
Thank you. Thank you for your input, guys. That's very helpful.
Anybody else? I think Prachi, I saw you going on mute.
Yeah,
Yourself.
hey, Jacob. Yeah, hi. I was just gonna agree with you, and I would say we have encountered the same thing. I think the problem of overcalling non-compaction exists more than undercalling it, I feel. And a lot of times you kind of just make that cut, and I agree with you that unless it really visually looks like it and it involves several segments, a lot of times it's not really truly non-compaction. But I can also share an interesting case with the group.
Oh, please.
Let me
make you a presenter.
Okay. And it's just some representative images because we used it or just submitted it for a publication. But it's so interesting that I would love to share it with you guys. So this was a 16-year-old, and the history is what makes this case truly interesting. So 2 days later after the Pfizer vaccine, the patient had high-level troponins, was admitted to the hospital with myocarditis, and then was treated and had an improvement on the subsequent following 2 days. But this is a 6-week follow-up cardiac MR. And you can see that the patient has subepicardial delayed enhancement, so very convincing myocarditis. So this was a vaccine-related myocarditis in this patient. And it's just pretty obvious. It's not one of those subtle ones, but subepicardial, extensive enhancement, and temporally fits in with administration of the second dose of COVID vaccine.
And in a 16-year-old.
In a 16-year-old, yes. Previously asymptomatic, 2 days after second dose of vaccine.
Wow.
That's kind of like,
We have,
go ahead, I'm sorry.
it's Carol. We have 8 patients admitted with post COVID vaccine myocarditis right now.
Wow.
Within what time period?
Just the last 3 weeks.
No, I mean, how far out from the vaccination they are?
Just a few days after, yeah.
Can you tell her it's the same patient, it's the correct patient? Yeah, so Carol, we have similar about 9 patients with COVID myocarditis here, but this was, the imaging was so striking. This was, I think, one patient where we had the imaging, which was really striking. So just thought I'd share it with everyone.
Beautiful.
It's a great case, thank you. All right. Thank you, Prachi. Anybody else has cases?
I do.
All right, let's see, Carol. I'm gonna make you presenter.
Okay, I'm gonna find my.
All right, we can see your screen.
Yeah, except it's the wrong date. There's May. Here's July. So this also, this woman had, she's 41, had shortness of breath for 3 months and cough when she lay down. She also just had her, she presented in around May 13th and had her COVID vaccine on the 6th. Her chest x-ray is unremarkable. Although you can see her Harrington rods, which did cause some artifact on the MR. Just some still images from her echo transthoracic, and what they described was thickening around the aortic root, but also some narrowing, and these aren't, I'm not very good at echo, but narrowing of the main pulmonary artery and the right pulmonary artery. And so this was felt to be possibly inflammatory and related to COVID vaccine. So she subsequently underwent cardiac CT. So I'm just going to go back up, and so you can appreciate marked or an infiltrative soft tissue mass around the aortic root and proximal ascending aorta, the coronaries, the main pulmonary arteries narrowed, as well as the right and the proximal left. The right coronary artery is buried in this infiltrative soft tissue mass and is occluded and reconstitutes more distally. So she I did a delayed CT just to see if there was enhancement of this mass, and really the myocardium was about 80 Hounsfield units, and this was 69, so no significant enhancement. Just some still images of the CT, some reconstructions depicting this mass.
Carol,
MR here.
quick question before you show the on the CT. When you said you did a delayed CT and or delayed enhancement, was that the 10 minutes like you would do for an MR, or how soon do you do it?
I only waited about 1 minute, but I'm going to show you another one where we waited 8 minutes.
Okay.
And it's a patient that was quite interesting. So here on the MR, you can see the right ventricle is, this isn't looping, dilated, and there's flattening of the septum during systole, so consistent with high pressure. And then these are axial cines through the heart, really not showing anything very different from the CT. Certainly the right pulmonary artery is extremely narrowed by this mass. There's a small pericardial effusion. This is the perfusion run, and no avid enhancement here. And these are the delayed images. Apologize about the artifact from her Harrington rods, but that there is enhancement. You can see it on this oblique coronal image along the top of the right pulmonary artery. So I don't know if there are any trainees there who want to provide their impression, a differential. Sorry, I joined late, so I'm not really sure who's there.
We have a nice group, so anybody wants to give it a try?
I'm a PGY5, so I can give it a shot. It might not be the best shot.
I'm sure it's gonna be great.
Close to the differential.
I mean, I guess I would just be mainly considered about a vasculitis, large vessel vasculitis. So I guess we've got narrowing of the pulmonary arteries. So I think that's classic for Takayasu's, but I can't remember the age of the patient.
She's 41.
So I guess I would go with most likely Takayasu's or some other large vessel vasculitis.
Would you consider anything else?
I guess infiltrating, I mean, I guess like a fibrosing mediastinitis maybe. I'm not really sure.
Okay. I think with vasculitis in general, I see smooth tapering as opposed to this kind of aggressive looking pattern of narrowing. it looks, you know, like large bites, and usually there's quite well-defined thickening of the wall that's more often symmetrical. Although, you know, I have seen Takayasu's do this too. But I might include some malignancies here, such as lymphoma or metastatic disease. Certainly METs are the most common pericardial malignancy. This is definitely within the pericardium. And then angiosarcoma is usually more vascular than this, but we always include it in the differential. Lymphoma and angiosarcoma tend to be more right-sided, involving the AV groove. This is not quite in the most common location. Anyone else think of anything else?
I think I would just
Hi, it could be IgG.
Yeah, go ahead, Julia.
Oh, excuse me. It could be IgG4 disease, or
Yeah, we thought of that
could
as
be.
well. So she did eventually, after many trials, have a open biopsy, and it was returned as lymphoma. So this was another case of lymphoma.
Other parts of the body, I think of it as encasing the vessels without like constricting or narrowing. So is that a exception in the heart? Because it seems like there was pretty profound like mass effect resulting in that narrowing.
Yeah, I would say that the ones I've seen that involve the heart have significantly narrowed chambers and vessels.
Thank you.
But vasculitis was also considered an IgG4. Okay, another case, 65-year-old woman with second-degree Mobitz to an intermittent complete heart block. This is just a really nice imaging case. Hopefully these will loop. Okay. So here we can see a thickening of the inferior septum, quite significant thickening more towards the apex, involving the entire septum. This is a little bit post contrast injection, so you can see something enhancing in the distal septum as well on the two-chamber view, again done a few minutes after contrast. I don't know if you do that at your centers where you do the short axis and then you inject and then continue doing the cines. That's what we do at our institution just to save time. So we often see the beginnings of enhancement. And I'm just going to move on to the perfusion, the four-chamber view, which shows no significant enhancement early on, no significant increased perfusion, but then on the delayed GAD, there's mid-myocardial and transmural patchy delayed enhancement in the septum, and also in the inferior septum here, in the inferior wall on the two-chamber view. So for the trainees, any differentials here? And recommendation maybe for further evaluation?
So I guess to me this looks like a focal infiltrative process. So I guess something like sarcoid could involve a single, like the interventricular septum, and also cause some of that thickening. I guess the thing that first came to my mind would have been amyloidosis, but we would expect that to be circumferential, which we're not seeing here. And so, I mean, to me, this looks like mid-myocardial and epicardial, or what do you call this, transmural?
You're correct. It's more mid-myocardial and sub-epicardial.
So then I guess myocarditis, I would also add to that, but I wouldn't really expect it to be thickened, so I'm not entirely sure what this is.
Well, I think sarcoid's very good. Is there anything you might want to recommend to further narrow your differential?
In terms of additional studies, or?
Is there any imaging?
I mean, if we were going along the sarcoid route, I guess just a chest x-ray to start out with.
Okay.
Otherwise, we can do like a CT chest with contrast.
Yeah, so they were normal.
And then I guess kind of along the other route that we were talking, I mean, this does not look like a classic mass, but maybe some sort of metastatic disease. I'm not entirely sure.
Yeah, I think you'd have to consider metastatic disease too from a distant primary. So there was no known primary. So then she had a PET CT, which I guess in the setting of malignancy could also not be helpful if you had, well, lesions that could also mimic sarcoid. But here we see that what we didn't see in the heart was I couldn't see any right and left atrial uptake. Sorry, I couldn't get the fused PET, but they described it as right and left atrial, which I guess is here, as well as right ventricular and left ventricular uptake, and then some nodal uptake, and really nothing in the mediastinal or hilar nodes. So she had a nodal excision, which was negative for sarcoid or malignancy, and then she eventually had a biopsy of the septum on the right ventricular side, and so this is sarcoid. So really quite mass-like and likely active. I didn't mention that it's unfortunate that we don't do any more T2 weighted imaging. We just do mapping. So mapping was abnormal in the areas of enhancement. So T2 was elevated, and of course T1 and ECV were elevated in the areas of enhancement. But I used to really like seeing the T2 weighted images in the presence of inflammation or edema. But we just do mapping. Have you abandoned doing T2 weighted imaging too to speed up your studies and just do mapping?
No, we use both.
You use both, yeah. That's nice. Anyway, a nice case of sarcoid, limited to the heart, which is unusual but can happen. And I think this is the case that Jacobo was waiting for. This is a 67-year-old man with a bioprosthetic aortic valve replacement 8 months prior, who presented with fever and malaise. At the time of his valve replacement, he had a normal coronary angiogram, and he's got new T-wave inversion in the chest leads. That was written on the rec. I don't know if that was correct. So this is a cine from the CT. We did a retrospective CT, and kind of as expected from the history of fever and malaise, there is thickening of the bioprosthetic aortic valve, and there's a vegetation that you can see moving on this cine, and then there's a small pseudoaneurysm that is communicating with the LVOT. And this is a cine. The left apex is here, and you can see that there is akinesis or dyskinesis at the apex in the distal septum, consistent with an aneurysm. And this is the 8-minute late iodine enhancement CT, showing transmural enhancement in the region of dyskinesia. No real thinning of the myocardium here. So in the setting of endocarditis with a vegetation and new ECG changes, and this pattern here, what do you think is the etiology and the finding?
So I guess thromboembolic event to the, I guess, left coronary artery,
Mm-hmm.
LAD.
Very good. So infectious endocarditis with probable embolic event to the distal LAD, and late iodine enhancement on the CT and aneurysm on the functional movie. So CT can do it all sometimes.
It's a nice case. You mentioned in the history, Carol, so the patient was septic?
He had fever and malaise.
Okay. So it was not the pseudoaneurysm was not infected. Was not a.
No, it was from an embolic event. Yeah.
Okay.
Yeah.
Nice. Great case.
So if anyone else has cases, I think we still have a few minutes. We have 15 minutes.
Yeah, I have a few cases too, but if anybody else on the call has cases, I'm more than happy to share the screen with you guys. Anybody there who wants to share a case? All right. Let me share my screen. I have a bunch of cases, but I don't think we have time for all of them. So then let me select a couple. All right, so this is a good case. All right, so I'm assuming everybody can see my screen because I have it here on the little window. So again, whoever wants to participate and make comments, that'd be great. So the screen change for you guys? Can you see the X-ray or no?
No.
No, that's weird.
Well, we can see your slides, I think.
Yeah, but
Yeah.
All right, so that's unfortunate that you cannot see the whole thing. If I hit play, let's try it again. No, it's it pauses the application for some reason. So let's show it like this. All right, so any thoughts about this, guys?
So I guess I would say upturned cardiac apex, so possibly a tetralogy
Okay, that's
would be the first thing that comes to my mind.
all right. Anybody else?
It seems like herniation in the pericardium of the heart. It looks like, but
Okay. So Jacob, so the other thing that to notice is not just the upturn, but to check the next 10 chest x-rays you look at the right cardiac contour of the heart. I mean, it's not rotated. The image it's pretty symmetric. You should see the right side of the heart to the right of the spine. Every time you don't see it, you see the right contours either overlapping and moving to the left. You should be concerned that there's some shift of the mediastinum. So there's upturning plus some shift as well. I'm going to show you. So this is the patient a little bit, some months before the one that I showed you earlier, and you can see there that the patient had surgery for pericardial penetration from a knife stab to the chest. I'm going to show you now a CT. Is this a movie? No, okay. And as we move down, any comments, any thoughts about this? So you can see there's a waist to the contour of the ventricles here and there. So there's, and you can see the pericardium here proximally, but you don't really see the pericardial layer distally on this patient. Let's look at coronal recon. And you see that left ventricle upturn, I guess, or elevation that was not present on.
So
Go ahead.
I guess I agree with whoever, I didn't catch who it was, but whoever said, I guess herniation through the pericardial defect.
Yeah, that was Dr.
Or I
Alegria.
guess of the wound, of the repair.
Correct. So this is a case of acquired pericardial defect post-stabbing with heart herniating through it. So during the surgery, there some pericardium was resected, and when you look at the images, it looks like there's partial congenital partial absence. This is more common than congenital, clearly, right? All the congenital absence of the pericardium is rare, and we're always doing heart surgery on a lot of patients, so clearly it's going to be more common. And again, manifested by, you can either see gas or the fluid sometimes along the pleural cavity or abnormal cardiac contours. And there's a tendency of the heart to herniate through defect. This was very interesting. That's something that I learned when I was researching to present this case was there's no correlation with the size of the defect, or at least has not been proven to be statistically significant. After lobectomy or pneumonectomy, there's reduced pleural pressure, and decreased pressure also tends to increase that suction of the heart through the pericardial defect. So that may put some of these patients at risk with this more than just a pericardiectomy that goes on in a patient. Also, when the patient may get a chest tube that's connected to negative pressure, also maybe sucking that heart through the defect as well. So these are a couple of things that may predispose for cardiac herniation. Well, we know that the heart is jumping around, so that also may play a part role of this. All right, let me try.
Sorry, so was that patient symptomatic, or was this incidental on the chest X-ray?
It was incidental on this patient. All right, let me see.
Did they fix it?
You know what? I don't know.
Okay.
I need to follow it up. I am trying to see. So I want to show you one more case, but I really want to be able to display the full screen so that the movies will play accordingly. So let me do this. I think this way. Yeah, this is the way it should work. So let's see. We fixed it. Okay, so this is a 36-year-old female, HIV positive, with failure to thrive and no history of congenital heart disease. So I'm going to show you a couple of slides. First, the axial movie. Just going to let it, well, the X-ray. Anything about the X-ray? Anything funny about the X-ray? I would suggest that maybe the left contour here at the region of the left atrial appendage is a little bit more prominent than usual. Maybe the pulmonaries, although when you see the branches of pulmonary arteries and veins here, the vasculature doesn't seem to be engorged, but definitely there's a bit of a bump here that seems more than we usually see. Okay, just gonna let this scroll back and forth. So even though you may be scrolling a bit more jumpy on your screen, if we let it enough times, you may get an idea. Any comments? Anything that looks weird?
I guess the main pulmonary trunk looks a bit funny. It almost looks like there's, well, I guess it's difficult to tell based off of this, but the contour looks right there, kind of right at the distal aspect of the common trunk.
Okay, let's look at, we're going to do the same. We're going to have a loop going back and forth in coronal reconstruction. It's a bit
I
slower.
have a case like that too.
There you go.
Yeah.
So it looks funny, but anything else that you can pinpoint at? And if not, that's okay as well. I'll show you something else. All right, let's do, so it's a VRT. And you can see the left pulmonary artery kind of crosses above and over the right pulmonary artery, almost like it saddles over it to some degree. Sorry, I think it's spinning a bit fast on my side. I don't know how it's doing on yours, but I think it's quite noticeable. All right, so this is what something called a crisscross pulmonary arteries. It's usually an isolated abnormality. Couldn't find really any cases in literature in an asymptomatic patient. This I guess is the first one that I see. Extremely rare and almost always associated with some sort of conotruncal abnormality or congenital abnormality. Again, but this was from, at least from this regard, it was a asymptomatic patient. Basically, what we see here is that the ostium of the left pulmonary artery originates superior to the right pulmonary artery and to its right, so it kind of crosses over, it saddles it, like we said. And that is that case. How are we doing with time? I think we have time for one last case. All right.
Might be also asymptomatic, Jacobo.
Yeah. Oh,
I just saw this
that you
like a,
saw?
so.
That's interesting. All
So
right. We have a series.
yeah, we just need one more.
All right, let's see. This is a 30-year-old male, no significant past medical histories, presents to the urgent care with headaches and numbness over the right side of the body, otherwise no focal deficits on exam. He was discharged on some medications, returned 4 days later without relief. CT of the chest was done, which prompted an MRI examination. I don't have access to the CT for some reason. I couldn't find it, so I'm just going to go straight to the MR. No chest pain, no shortness of breath. So again, some brief neurotype symptoms, and chest imaging recommended a cardiac MR. So immediately, so what are we thinking of?
I guess he's young to have like a Pinkus tumor, but I would expect possibly some sort of maybe like SV or SVC syndrome or some other sort of mass in the upper mediastinum.
Okay, so you're thinking about the numbness on the right side of the body, etc. So yeah, but also let's think about the headaches and then the numbness as well. So maybe something like TIAs, or we may be thinking of something along. Is there a shunt, a PFO, or something, or is there a source of emboli, or what? If there's anything that can explain the symptoms, and then of course the CT prompted the MR, which kind of makes us think, oh yeah, there is something going on in the heart. Okay, is this your steady state free precession? It's near a 4-chamber view, a little bit high. Any comments here? Anything looks weird? So I'll show you here. There's a I don't know if my cursor, but there's a mass there in the right ventricle. Looks ovoid, complex, multiseptated. Maybe there may be some sort of pedicle associated with it. It's not moving terribly much, but there seems to be there's definitely a mass in there. Let's see. This is your T1 image, and there you can see that mass, and again, complex with at least an area of increased signal intensity, similar to the subcutaneous or the epicardial and pericardial fat. So we do the same imaging here, the black blood imaging, but we put some, this is your T2. So you see also there's increase in that signal. So they may be mucinous or have the high water content in it. This is your PSIR, I believe. So you have some increased signal intensity associated with that mass as well. Again, just very complex, funny signal. It's a T1 post contrast. Again, some areas of enhancement there. So complex. I'm sorry, this is your PSIR. Again, the septations are the ones that are showing that enhancement to some degree, but there's areas that are cystic, like we had seen before. So no enhancement there. So we have a complex, multi-septated mass in the right ventricle, has areas of look like fat, areas that look like mucinous content. Any thoughts of what that can be, those very complex? What if you had one of these somewhere else in your body, like let's say an ovary?
Teratoma,
Teratoma is a great thought.
or like a dermoid or teratoma. Yeah.
Yeah.
Is this a man?
This was male. Yeah.
Man, yeah.
So again, SFP, T1, fat sat, some T2, black blood T2s. This is the early enhancement ones. So, and then your PSIRs, your phase sensitive inversion recovery or late gadolinium enhancement images. All right, so this is another view of that PSIR in the short axis. So let's see, they took him to surgery and the surgeon says, able to open the right atrium. There was a ventricular mass deep down into the RV. Well encapsulated. All the cords were attached from the anterior and septal leaflets to the tricuspid valve to this large mass. It was carved out, removed from the cords of the leaflets of the tricuspid valve. At the end, the valve was pretty much damaged after all of that resection. So about the size of a golf ball. And it was sent to pathology, and here's from pathology. So it was a mature cystic teratoma containing multiple cysts lined by respiratory, mucinous epithelium, cartilage, salivary gland tissue, and small foci of brain tissue in it. So again, pretty classic teratoma, just a lot of tissues from everywhere. No malignant elements were identified. So again, a young patient presenting with this type of lesion. So I went to search for an intraventricular teratoma. This is what I found. They're all in the brain. I guess you have to be a bit more specific on your search criteria. So I switched it to intraventricular cardiac teratoma, and still a bunch of brain teratomas, but we do see that they do happen in the heart. There's a few reports out there. So it's rare, benign germ cell tumor, contains all three germ layers, endodermal, mesodermal, and neuroectodermal elements. It's almost always in the infants and children. Is the second most common primary cardiac tumor in fetuses and neonates. So what's the first one? Who remembers what's the most common primary cardiac tumor in fetus and neonates? That's going to be the rhabdomyoma, right? Which can be associated usually with tuberous sclerosis. So this is going to be, I mean, those are rare. This is the second most common, so it's even more rare than those. However, over 90% of those are going to be related to the pericardium, attached to the pulmonary artery and the aorta, so much higher, and really rare to be within the cardiac chamber, like in this case. So they result in effusions, which may lead into tamponade or other type of compression of the chambers, which again will make the patient symptomatic, which this patient did not have cardiac symptoms per se like this. Again, intramyocardial teratomas are rare, may present with congestive heart failure. You have to take them out. They can be difficult to take out. but once out, it's rare that they're going to record or have a malignant degeneration. A bit more, we saw all of this, right? Cystic solid components may appear iso, hypo, or intense on T1, hyperintense on the T2 images. Hypointense at first pass perfusion, which differentiates them from hemangiomas, which we usually see in similar location about the root of the large vessels near the origin of the PA and the aorta. And again, like most teratomas, they can have fat content or calcifications are usually helpful for the diagnosis. This is from the literature, just a couple of cases. Again, this is where you usually see them, right by the origin of the large vessel. So this is just lateral to the pulmonary artery. Looks almost like a pericardial or cyst, but it's shown to be a teratoma. And this, again, this is a fetal MRI, different views. And again, these are all from the literature. So you can see here just a very heterogeneous intracardiac mass there to the right of the right ventricle. So there where the asterisk is on that bottom left image, or image B of that composite image. All right, so that's it for now. And with that, I think it's time. So yeah, it's about time. It's 5 o'clock. So I want to thank everyone for joining us, for showing cases, for being a part of this meeting. Hope everybody's doing well, and looking forward to seeing you guys next month for another session of NASCI's Curious Cases. Thank you all.
Thank you very much.
Thank you.
Thank you very much.
Please take over.
Stay safe.